Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Jennie Berkovich, board-certified pediatrician and director of education for JOMA. My guest today is Dr. Paul Offit, a man who needs no introduction. However, he is the director of the Vaccine Education Center and professor of pediatrics in the Division of Infectious Disease at Children's Hospital of Philadelphia. He is the Maurice R. Hilleman Professor of Vaccinology at the Perelman School of Medicine at the University of Pennsylvania. Dr. Offit is an internationally recognized expert in the fields of virology and immunology and was a member of the Advisory Committee on Immunization Practices to the CDC. He's a member of the FDA, Vaccines and Related Biological Products Advisory Committee, and a founding advisory board member of the Autism Science Foundation and the Foundation for Vaccine Research. He's a member of the Institute of Medicine and co-editor of the foremost vaccine text, Vaccines. He's, of course, one of the main developers of the rotavirus vaccine, which has saved many, many lives. And most importantly, he's been somebody that I have looked up to and been wanting to speak and interview for a very long time. So it was a very special treat for me to meet him. I hope you enjoyed the episode. Hi, Dr. Offit. Welcome to the podcast.
Thank you. Thanks for asking me.
I wanted to start with, honestly, vaccine hesitancy, but I wrote these questions before everything started happening with measles and the cases that are happening in Texas. So I actually think I'm going to start there. We're in the middle of what many are calling a measles outbreak. I've seen this before, even in my sort of short career. I would love to hear from your perspective if what we're seeing now is similar to other outbreaks we've had in terms of measles, or does this one feel different in any way?
Similar in some ways, different in others. So in 1991, 1992 in Philadelphia, we had an outbreak that centered on two fundamentalist churches, which were actually faith-healing churches. So they didn't believe in medical care, period, not just vaccines. So during that sort of 3-month period, we had 1,400 cases of measles and 9 deaths, which is a death rate of like 0.6%, which is high. In 2018, 2019 in Brooklyn, centering on, again, Orthodox Jewish community, there was another outbreak that involved about 650 cases, so no deaths. In California, there was an outbreak 2014, 2015 that centered on a sort of community that really was kind of the all-natural, don't inject me with anything that has a chemical name, that sort of spread to 7 states as well as Mexico and Canada, that involved about 300 cases, no deaths. And in Netherlands, there was a 1999 to 2000 outbreak that centered on an Orthodox Christian Reform community that involved about 3,400 cases and 3 deaths. So a death rate of around 0.1%, which is what you would see. What's odd about this outbreak is really in the first 124 cases, you had a death. In the first 200 cases, you had 2 deaths. That's a mortality rate of 1%, which is much higher than you would expect. And it makes you think one of a few things. One is that they have vastly underestimated the number of cases, which I think is likely because these groups, this Mennonite group, this sort of Anabaptist sect group, are generally resistant to sort of outside people coming in and doing things like testing. And 2, it's rural West Texas. So I'm just wondering about the quality of the care for someone who has severe pneumonia and requires sort of intense respiratory care. So I think those 2 things may be what's going on. But so that's what makes it unusual. Remember that child who died, which was a 6-year-old girl who was previously healthy. That's the first child death for measles in this country in more than 20 years. That last case was in 2003.
I want to expand on the fact that you mentioned this particular child. We know they passed away from pneumonia. I find that, at least in like layman news sources, that's really like emphasized as being the cause of death, and the measles piece is de-emphasized. I read a really painful interview with the family of
the parents who lost a child, and they really felt like, from their perspective, the measles had resolved and she developed pneumonia, and because of their either lack of care or not feeling like the care was adequate, that's ultimately why the child passed. I would love to hear your perspective on that.
Well, from what I've heard, it's measles pneumonia. I mean, measles is a pneumonia. Measles virus can reproduce itself in the lungs and cause severe and occasionally fatal disease. I think when people hear the word pneumonia, they think bacterial pneumonia.
Mm-hmm.
There's a bacterial superinfection on top of what was a measles pneumonia. But you can typically, what you die from with measles is a measles pneumonia. And so I don't distinguish those two things.
So let's talk about prevention, and one of my favorite thing, which is the vaccine. How good is the measles vaccine at preventing significant disease and death?
It's remarkable. Really, one dose of measles vaccine is 93% effective at preventing measles. Measles, period. Mild, moderate, severe. And although it doesn't cover an additional 7%, still those 7% are still much less likely to have severe disease. We could have eliminated measles in this country with a single dose. We could have. I think we gave a second dose in 1989. So the first dose came out in 63. The last best measles vaccine was 68. And then the second dose recommendation came in 89, because around that time there were tens of thousands of hospitalizations and about 150 deaths during about a 3-year period. So we had a second dose recommendation. But if you look at the epidemiology, meaning who was getting sick during those outbreaks, it was people who weren't vaccinated at all. So this was really a second chance to get a first dose. So when people call it a measles booster dose, it's really not. It was just a second chance to get a first dose. So for example, if you just got one dose of vaccine, which is likely if you were born between 1968 and 1989, that's fine. You don't need to get another.
That's interesting. I have a few questions about how we got to a place of hesitancy around the measles vaccine. But one of the things I hear, even from my own patient population, is, well, they have one measles vaccine, right? Typically it's the MMR. They have one MMR. We typically, if we follow the schedule as it's recommended, we give that at the 1-year well visit. Why do we need a second one?
Yeah, so I would say that for the measles vaccine, probably a single dose would have been fine. Not true with the mumps vaccine. I mean, the mumps vaccine is not as effective as the measles vaccine. So that second dose really helps. In fact, when there were outbreaks of mumps, as you've seen sort of in the last, say, 10 years or so, especially on college campuses, there was a recommendation for a third dose. Bell is sort of also excellent, but again, benefits from a second dose. Because those vaccines are given together, which certainly makes it easier for the child. So you get one dose instead of 3, or in the case of a 2-dose vaccine, 2 doses instead of 6. I think it's a value. So that's why you get that second dose.
So let's talk about kind of how we got here. Would love to hear your perspective, at least historically, on the hesitancy surrounding the measles vaccine.
I think, before there was measles vaccine, 1963, people like me who were old and were born in the 1950s had measles. At that time, there would be 3 to 4 million cases of measles. There would be about 48,000 hospitalizations, primarily for pneumonia, for measles pneumonia, and to a lesser extent, dehydration, and to an even lesser extent, measles encephalitis, which means measles infect the brain and cause deafness and blindness. I mean, so that was that. And so what happened was, with that first dose recommendation in 63 and then the last best vaccine in 68, you started to see a dramatic decline in measles. Great. Then we had those outbreaks in the late 80s, early 90s. So we had a second dose recommendation. And then we did something that was remarkable. We eliminated, by the year 2000, the most contagious infectious disease, not just the most contagious vaccine preventable disease, the most contagious infectious disease. More contagious than Ebola, more contagious than Zika, more contagious than COVID or flu. It is the most contagious disease because it's not just spread by face-to-face contact. It's an airspace disease. You don't have to have contact with someone with measles to get it. You just have to be in their airspace within 2 hours of them being there. That's how hard this virus is to control. Really, it's 5 times more contagious than say COVID was. But we eliminated it. That second dose recommendation, because we had at least 95% of the population vaccinated, eliminated measles from this country, which was the good news. The bad news is it also eliminated the memory of measles. So 25 years ago, we eliminated this virus, but people don't remember it. Memory has faded. And I think not only have we eliminated it, we've eliminated the memory. And with that, you're now seeing people being pretty complacent about, well, it's no big deal. I mean, the word measly comes from measles as if it's no big deal, but it's a big deal. Measles was never a rite of childhood passage because many children didn't actually successfully get past that virus.
And so as a result of that, we developed this sort of not serious approach or lackadaisical approach to the vaccine?
Yeah, I think people, if you don't experience it, if you don't see it, then you just don't think it's real. I mean, same thing with polio, right? I mean, people think of polio, they think of all
Yeah.
those white pictures. I was in the polio war when I was 5 years of age, so I certainly remember that disease. I
Wow.
remember the children in iron lungs. I remember the so-called Sister Kenny hot pack treatments, which was applied to withered arms and legs and children screaming. That was a bad disease. That is not a disease you want to come back and I see come back. What really worries me in this time of complacency is you see um, misinformation can gain a much greater foothold when you're not scared of the disease. If you're not scared of the disease, and my children were born in the 1990s, I mean, I wasn't scared of all the diseases my grandparents were scared of, or my parents were scared of. And that's the problem. Because if you're not scared of the disease, then you're going to focus on safety issues, real or imagined.
Hesitation or a concern that I hear very often from patients when we talk about needing to get a vaccine with measles is that, well, we don't know the effects of it, right? You mentioned that vaccine's been around since the 60s. Has that always been the case? I imagine when it first came out, I mean, it was probably like extraordinary, right? This was a disease that many were getting very sick, kids were dying from, and now all of a sudden we had a way to prevent that. So it's puzzling to me that now, decades later, we're having the concern of like, well, we don't know the long-term effects of this vaccine.
Vaccine's been around for more than 60 years. A lot of experience with this vaccine. And the last best vaccine was in 68. So we've had a lot of experience with the current vaccine. You know, usually when you have side effects from vaccines, and vaccine side effects can be serious and it can occasionally be fatal. It's true. I mean, if you look at the Johnson & Johnson COVID vaccine, which was licensed or at least authorized for use in February of 2021. I mean, that vaccine was a rare cause of clotting, including clotting in the brain, including fatal clotting in the brain. It was rare, sort of 1 per 250,000 doses. And the problem was quickly picked up. But it's invariably true with vaccine side effects that are severe. For example, the oral polio vaccine could itself cause polio. Again, rare.
The oral one, which we don't give in the United States, just so
We haven't
make sure, right?
that in the country since 2000. So we haven't used that vaccine for 25 years. It's still used in the world. It was a rare cause of polio. Again, 1 per 2.4 million doses, but certainly real. But in all those cases, it's the immune response to the vaccine that's causing those symptoms. The influenza vaccine is a rare cause of something called Guillain-Barré syndrome, which is this ascending paralysis. Again, can be as frequent as 1 in a million, often less frequent than that. But again, these are all because you're making an immune response to the vaccine, which usually occurs within 7 to 10 days. And that's why when you do vaccine studies, you always wait till 2 months after the last dose to give yourself a margin of safety to make sure you'll have plenty of time to see if there was a vaccine side effect. But the notion of long-term problems, that it's going to appear 10 years later, 20 years later, it doesn't make sense because it's invariably due to the immune response, which is almost immediate.
I worry that when we present all the potential side effect from the vaccines, which are right, true, and that it can become really overwhelming for a parent or a family that's trying to make a good decision. I'm trying to obviously do the best thing for their child, and they're thinking to themselves, measles. Gosh, I don't know. Like, I'm not in Texas. I don't think my kid's gonna have measles. I don't know anybody that's had measles, but these side effects from the vaccine sound scary. Why would I risk it? How do you have that conversation?
Well, firstly, regarding measles, it's not just Texas anymore. There's at least 12 states and maybe more that have now experienced measles cases. And once measles gets a foothold, it spreads like wildfire. I mean, I certainly understand that we're not scared of these diseases anymore. But when you start to see them come back, so for example, in Rockland County, there was a case of polio in a 27-year-old man. Polio only paralyzes 1 of every 200 people it infects. When you see a case of paralysis, he is the tip of a much bigger iceberg. And when you look at wastewater samples, not only in Rockland County, but in New York City or in surrounding counties, you saw evidence of that virus. And I think that's also true if you looked in wastewater samples in Philly or Chicago or Los Angeles. You would still see that virus because it's a so-called it's derived from the oral polio vaccine. And the oral polio vaccine is still given in this world, and people still come here from other countries. So that virus is around. Lower immunization rates enough, you will see polio come back. And I think it's a dangerous game we play. I understand how people have this kind of notion of invulnerability. And I feel the same way about my children. I mean, when we vaccinated our children in the 90s, I never imagined them getting these diseases. These diseases were largely gone by then. But nonetheless, all you have to do is talk to certain parents in advocacy groups like Families Fighting Flu or Meningitis Angels or National Meningitis Association. These parents all tell the same story. I can't believe this happened to me. What happens to them? So because the benefits of vaccine clearly outweigh its risks, it's worth getting these vaccines.
The conversations or my approach to speaking to vaccine hesitant families has dramatically changed. I would say pre and post pandemic. I find that there's a significant erosion in trust that families have, both from like the medical system as a whole, and then vaccines in general. Have you seen the same?
Yes, I think the COVID pandemic has caused a massive amount of distrust in public health agencies, frankly, in the federal government, period, not just in the FDA or the National Institutes of Health or the CDC or the Department of Health and Human Services. I think it also spills over to the FBI or to the Department of Justice. And in fact, if you look at many of the hires President Trump has for each of these agencies, they often have disdain for the agency that they're heading. That sort of seems to be a requirement for heading that agency. Yeah, I think it was sort of the 1-2 punch that happened during COVID. I think in 2020, we didn't have anything to try and prevent a virus that was killing hundreds or thousands of people a day. We didn't have monoclonals or antivirals or vaccines at the end of the year. And so what did we do? We shuttered schools, we restricted travel, we closed businesses, we isolated, quarantined, masked, tested. And I think people saw that, or a significant percentage of people saw that as massive government overreach. And in 2021, when we had vaccines and mandated them for work. So you may lose your job if you didn't get a vaccine, or you couldn't go to your favorite bar or restaurant or sporting event or place of worship. That too was seen as massive overreach, and people pushed back hard. Also under the name of the medical freedom movement. Don't tell me what to do. Don't tell me I have to mask. Don't tell me I have to vaccinate. And I think that spilled over not just to COVID vaccines, but to all vaccines.
Yeah, I think unfortunately it has. So then I think my next question is how do we recover? How do we rebuild the trust and how do we move forward?
I can easily answer that question. I have no idea. I guess we'll see. I think the best we can do is to keep trying to explain the importance of science, the importance of good public health, and hope that we can explain it in a compassionate way and passionate way and compelling way, much more, I think, with story than with data or numbers, and then hope for the best. The example I'll use is you look at, so the NIH is now currently being cut back. No one can do now, I think we're about to see all mRNA research being eliminated, which is remarkable to me. I mean, this vaccine, the mRNA vaccines, probably saved about 3 million lives. And people think, well, look how quickly it was developed. I mean, here we isolated the virus in January of 2020. We had 2 large clinical trials by November of 2020, December, November of 2020. That was developed very quickly. But really, when you look at it, mRNA technology was funded back in 1997 by NIH. And who did they fund? They funded Drew Weissman and Katie Carrico, who won the 2023 Nobel Prize in Medicine for that work. And in 2002, 2003, when SARS-1 raised its head again in China and spread across the world, but not into the United States, there was NIH work done making an mRNA SARS-1 vaccine, which we never used because the virus didn't spread here. But by the time SARS-CoV-2 hit, COVID hit, we had a lot of information that had been generated by NIH. And I think people didn't realize that. They don't.
They didn't. It wasn't publicized, and so I think when people hear mRNA, there's a lot of fear. It sounded new. It felt new. The way the vaccine mechanism was presented was like, this is a new type of way, which it wasn't. But I think that the messaging got lost.
You're right. We could have explained this better. I think we were trying to build an airplane in the air, and it was hard. But, mRNA, messenger RNA, is a natural product. I mean, most cells have about 200,000 pieces of mRNA in them, and messenger RNA is then sort of translated to become a protein. And so those cells make the enzymes and proteins necessary for life. This makes a different protein. It makes the protein that sits on the surface of SARS-CoV-2 virus. It makes it for a few days and then disintegrates, and you make an immune response. It's really a remarkable technology, and it worked remarkably well with pretty limited side effects. I mean, the mRNA vaccines could cause myocarditis, which is inflammation of the heart muscle, but for the most part, that was transient, self-limiting, self-resolving, unlike the myocarditis caused by the virus, which could be fatal.
I'm curious. Well, I have my own theories, but would love to hear yours. Like, why is mRNA a concern? Why is that technology, why is it on the radar to be cut of all things?
Because it's a gene. And I think that when people hear the word genetic, they think that's different. and that's going to alter your genes. And people were much more comfortable, for example, with Novavax's vaccine, because that was a purified protein vaccine. So they're used to that. I mean, that's the way the hepatitis B vaccine was made, or the human papillomavirus vaccine was made. So they're used to viral proteins. But the notion that you're injected with a gene, that could somehow alter your genes and cause you to have cancer or autoimmune diseases. Although I never understood why it is people thought that your genes would also always be argued altered for the worse. I mean, why couldn't it make you like Spider-Man?
Maybe it does. Now we won't know. They cut that funding.
That only happens when you're bitten by a radioactive spider, but go ahead.
There you go. You heard it here from Dr. Offit. You need a radioactive spider. One of the other things that's come under question recently is the vaccine schedule, right? Like this is the recommended childhood vaccine schedule is something that most general pediatricians like myself have sort of seared in our brain, and there's all sorts of nuance to it in terms of intervals between different doses and a catch-up schedule and special populations. And this schedule is under question. It's under question both from like a medical fundamental government question, also comes up a lot in individual families and patients that I take care of. Why do we have to give this vaccine now? Why do we need another dose of this? How did the schedule come to be?
Right. Well, I would say this. I think we ask a lot of parents in this country. I do. I mean, we ask them in the first few years of life to vaccinate their children against 14 different diseases. That can mean as many as 25 inoculations during that time. It can mean as many as 5 shots at one time to prevent diseases most people don't see, using biological fluids most people don't understand. I would be surprised if there wasn't pushback against vaccines. I think you should be skeptical of anything you put in your body, especially vaccines, because they're given to healthy children. The schedule comes about based on when people are most likely to get sick and how many doses it requires to induce a protective response. So, for example, if you look at diseases like rotavirus, which is a cause of fever, vomiting, and diarrhea, or pneumococcus, which is a bacteria that causes bloodstream infections and pneumonia and meningitis, or a bacteria called Haemophilus influenza type B, which causes the same thing as pneumococcus. You start to see those diseases around 6 months of age. So you need to be immune by then. So that's why you have it there. You take a vaccine like human papillomavirus, which is really preventing a disease that's solely transmitted by sexual contact for the most part. You don't really need to give that to a baby. You can give that to an adolescent. So hence that is an adolescent vaccine. But I think and so you have really vaccine to prevent 17 different diseases in the first 18 years of life. And so when people see all those shots, all those inoculations, they can't help reasonably to feel my immune system is being overloaded with all these vaccines. But it's not really the number of shots that matter. It's the number of immunological components in shots. And by immunological component, what I mean is for a viral vaccine, viral proteins, or for bacterial vaccines, bacterial proteins, or the complex sugar that sits on the surface of bacteria, bacterial polysaccharides. If you add up all those immunological components, all of them, you get the number around 160 or 170. And that sounds like a lot. But if you look 100 years ago, when we only had one vaccine, the smallpox vaccine, smallpox is the largest of the mammalian viruses. It's the only virus you can see under a light microscope. You don't need an electron microscope to see smallpox. It's that big. And it has 200 immunological components. So we actually, in the one vaccine we gave 100 years ago, had a greater immunological challenge than the 17 vaccines that we give now. And I understand how people see it as shot after shot after shot, but it's really the number of immunological challenges that matter more than just the number of shots.
I think that can be really confusing. It's confusing to me. I think it's not straightforward. I think it can be confusing to a layperson. So certainly, I agree. I like your perspective of understanding where the hesitancy come from and the perspective that we ask a lot.
I guess how can I explain that better so that it's less confusing?
No, I don't mean I'm confused now. I just mean it's something that I think needs like a little bit probably of some fundamental understanding of the science and I don't know, biochemistry, I guess. I think people really get focused on the number of shots. I think, they always ask me how many shots today, and can we split up the shots, and can I have some now and some later? Why do we not recommend that?
Why do we not recommend splitting up? So in order for a vaccine to be licensed and recommended, it has to go through a series of tests. You have to prove that it's safe and effective in so-called phase 3 studies. Further, you have to prove that it doesn't interfere with the safety profile or the immunogenicity profile of existing vaccines, and that those that would be given at the same time. and that those vaccines don't interfere with the safety or profile of your vaccine. So those are called concomitant use studies. So you have to do those studies too to prove that there's no difference. So it's a well-hewn schedule. To make up your own schedule is to do something that hasn't been tested. So you don't know whether or not there's any sort of interactions that haven't been looked for because it's never been tested. Also, you give these vaccines at a certain time because you want to protect children by a certain time. So to delay them and space them out is only to, one, make up a schedule that's untested, and two, put children at unnecessary risk because you're making a delay with no benefit. I'm going to try one more time on explaining why you're not overloading the immune system. But so viruses are made of proteins, as are bacteria. They're made of proteins, and it's the proteins that induce an immune response. So you look at SARS-CoV-2, for example, the cause of COVID. The mRNA vaccines or the Novavax vaccine is all inducing an immune response to one protein. And that protein is the protein that sits on the surface of the body, the so-called spike protein, surface of the virus. And so that's what matters. That's the immunological challenge. The immunological challenge from COVID is one protein. The immunological challenge from the smallpox vaccine was 200 proteins. That's a bigger immunological challenge, a much greater challenge. And that's why, if you look at people who got the smallpox vaccine, they invariably had large lymph node swelling of the lymph node, which is just a collection of immune cells under the arm where the shot was given. Often very large, very painful, and associated with fever with shaking chills. That was quite a challenge, the smallpox vaccine. And that was just one vaccine given 100 years ago. Today, because there's been advances in things like protein chemistry or protein purification, or so-called recombinant DNA technology, which is what's used to make the hepatitis B vaccine. The vaccines are really safer and purer than ever before, and are really, in total, a much lesser immunological challenge than just that one vaccine you got 100 years ago. Okay, that's my second attempt to try and explain this.
No, that was perfect. How, if at all, does this concept apply to combination vaccines? Because that's also sometimes I find parents will say, okay, I'm ready for the MMR, but I just want the measles component. I don't like the combination.
Right. Well, so first of all, that's not available. So it's not available separately. Although interestingly, if Merck did that, honestly, I think they would make more money off their vaccine if they pulled it out, because there is a demand for that, and I think they would probably make more if they pulled it out. But I think responsibly they haven't pulled it out. But again, if you look at that, it's so again, let's go back to my protein analogy. Viruses are made of proteins. So if you add up the number of proteins in that MMR vaccine, it adds up to 24. That's it. 24. Not a lot. You can separate it out so you get 10, 9, and 5, but that's not going to be a dramatically lesser challenge to your immune system. It's also well tested. The MMR vaccine's been around since 1971, so you have more than 50 years of experience with that vaccine.
There was a famous, or rather infamous, a study which we subsequently know was not true and hasn't been founded in any way, suggesting there's a potential link to the MMR vaccine and autism. How have you seen that particular myth evolve?
So in 1998, a British researcher named Andrew Wakefield published a paper in a journal called The Lancet, which was a well-respected general medical journal that had been around for like 100 years. And so the fact that he was a well-respected researcher, he worked at a very good institution called the Royal Free Hospital in London, and he published a paper in a well-known, reputable scientific journal. So any reasonable person would assume that publication had to be peer-reviewed and was accepted as being valuable. So what was that study? It really wasn't a study. It was a case series, meaning a collection of cases of 12 children who had recently received the measles, mumps, rubella vaccine, and then within a month of receiving that vaccine, developed signs and symptoms of autism. So it raised the question. The nicest thing you could say about that paper was it raised the question of whether MMR vaccine could cause autism, but it didn't prove it, because you're just looking at got a vaccine, had a problem. You can't really say whether or not the vaccine caused the problem unless you look at children who did or didn't get that vaccine to see whether or not the incidence of that problem was greater in a vaccinated group, because that's the only way to prove it. And so then what was done were more than a dozen studies in 7 countries on 3 different continents, looking at tens of thousands of children who either did or didn't get the MMR vaccine. And those aren't easy studies to do. You obviously can't do them prospectively, meaning give children MMR vaccine or not give children MMR vaccine because you can't ethically expose children to measles, mumps, and German measles. So it's only done retrospectively, meaning looking backwards at children who did or didn't get that vaccine. And when you do that, you remember that a child who doesn't get a vaccine as compared to a child that does get a vaccine may be different in terms of their socioeconomic background, different in terms of their healthcare seeking behavior, different in terms of their medical background. So you have to control for those so-called confounding variables, the things that may give you a result that's really not accurate. And when that was done over and over and over again, you could see that the MMR vaccine didn't cause autism. And ultimately, that paper was retracted. And it wasn't retracted because it was wrong, even though it was wrong. It was retracted because it was fraudulent. Because what that researcher had done is he'd misrepresented biological data. He'd misrepresented clinical data. There was at least one child in that study who developed symptoms of autism before he ever got that vaccine. He had a patent on his own safer measles vaccine, which was bogus. He received hundreds of thousands of dollars from a legal services commission to basically launder legal claims through a medical journal. And so, which he never mentioned to many of his co-authors. And I think for that, he basically lost his license to practice medicine and then came to the United States where he could continue to put out his message that MMR caused autism, even though study after study showed that he was wrong. So he's been marginalized. But I think once you raise the question, once you scare people, it's really hard to unscare them. It is.
For sure. It's a famous Paul Offit line that I use often, right? Once someone is scared, it's hard to unscare them. And so I recognize that once this information was out there, even though tons and tons of research came out afterwards saying that this link did not exist, it became something that we all had to address, especially with families as it was coming time to get this vaccine. I want to change gears a little bit and talk about what's next in vaccine education. Are there any new vaccines on the horizon or any infectious diseases that you think upcoming vaccines will be targeting?
So I think the one I would have said, a year ago was RSV, respiratory syncytial virus, which is probably the most common reason children get hospitalized. So now at least we have some arrows in our quiver to fight against that. So that's good. Things that are upcoming, I don't really see. I mean, I think that it'd be interesting to see whether the mRNA technology, assuming we're still able to use it, given what is now being cutbacks at the National Institutes of Health regarding researchers who are doing mRNA work. I mean, it would be interesting to see whether there is value in that vaccine to prevent HIV, the cause of AIDS, or to get a malaria vaccine that is better, or a tuberculosis vaccine that is better. But I really fear that the current administration has stifled that research, so we're not going to know about that. Adjuvants, which are those something that's added to vaccines to enhance the immune response. There's a lot of interesting work on that, so we'll see what happens. I don't see a vaccine immediately on the horizon as I did for the RSV vaccine.
I really was hoping you would say like one of the common cold viruses, adenovirus, something that that we pediatricians see often that causes a lot of havoc. But definitely, I think that the RSV was really, really exciting when it first came out. But again, I'm finding that it's at least maybe it's just in my own patient population. Maybe this is the case everywhere that I'm not having a ton of uptake, not having a ton of success getting families to vaccinate their child against it. Although my background is I was a hospital pediatrician before moving into outpatient. So I saw a tremendous amount of RSV. I saw babies die from RSV. So I really thought it would be one that everyone was equally excited about, but that really hasn't been the case.
That's too bad. I mean, fine, either as a maternal vaccine, it's a value, or as vaccine given to as passive vaccine, giving a monoclonal antibody that is long acting that can prevent the disease, for a fairly long period of time. And in that critical first year, it's really the less than 6-month-old that is really suffers this and dies from it, especially the less than 3-month-old. So that's the period of time. So the maternal vaccine then will protect the child for the first few months, or giving that monoclonal antibody. But again, safe, effective, and unfortunately underused because the word vaccine sadly has become a dirty word. I fear.
Yeah, I agree. I want to end by asking a question that I ask many of the guests on the podcast is if there was like one message that you could share or something that you find yourself saying or sharing with your patients over and over and over, what is the one thing that you wish like everyone would know?
Vaccinate your child. I mean, your job as a parent is to put your child in the safest position possible. And vaccines do that. I mean, if you look at the transcript, and you said you had done that with a parent who lost that 6-year-old girl, they had a choice. I mean, they chose not to give the MMR vaccine. And with that, you put your child at unnecessary risk. And I think that's impossible to handle I do. I mean, it is hard enough to lose a child, but the mere notion that you may have had something to do with that is something you can't live with. And I think what the anti-vaccine groups have provided to that parent is the notion that the measles vaccine kills children, that the measles vaccine causes blindness and deafness, that the measles vaccine doesn't work very well. And so what they offered her was a way out, because now you could say, well, not to give, if I'd given the vaccine, I also could have resulted in the child's death. Is completely wrong. I guess the experience I had when I was a fellow at Children's Hospital Philadelphia was in 2009. There was a swine flu pandemic, and there was a mother of 4 or 5 children who vaccinated all her children except for her youngest boy, who was maybe 5 or 6 years old. She thought he was a vulnerable child. She just didn't want to give him a vaccine, so she didn't. So he got flu. Came into our hospital, initially just had face mask oxygen, then he had continued positive airway pressure, so-called CPAP. Then he was in the intensive care unit. Then he was on a ventilator. He was on an oscillator. He was on a heart-lung machine for at least 1 month and maybe longer. And when it was over, he lived, but barely. And he had residual brain damage from what was, I think, periods of low oxygen in his bloodstream. And when it was over, I asked her how she would describe her experience. And she said she was glad she didn't give that vaccine. If she'd given that vaccine, it would have been much worse. And at the time, it struck me, but sort of thinking about it later, how do you live with yourself? I mean, if the notion that you could have hurt your child is just something you can't live with. And so you need something else. And I think what the anti-vaccine activists provided that mother and father, in that community was a way out. Vaccine would have been just as bad.
That makes a lot of sense. I heard you speak a few years ago. It was during the pandemic. It was like a Zoom grand rounds or something of the sort. And I remember you saying that when during your weeks of service in the infectious disease, right, as an infectious disease attending, you'd be rounding and you would have kids that were very sick, often from, not often, I guess, right, occasionally from a vaccine preventable disease, and they would be unvaccinated. And you often would have parents tell you, I did my research. And I always thought that was so funny. They were telling Paul Offit, like, right, that they did their research. But I think ultimately, right, I think you can't really reconcile the fact that it was preventable and you didn't make the right choice for your child that ultimately ended up being devastating.
Yeah, I think you hit on something that's really important. I think, what does doing your research mean? I mean, what I think it meant to those parents is they go online and look at other people's opinions about the vaccine. I mean, if you really want to do your research, read all the papers that have been published on that subject from medical journals. Read those journals, which means at some level you would have to have an expertise in virology or immunology or epidemiology or infectious disease, which most parents don't have. And frankly, most doctors don't have. So at least traditionally, we have looked to those advisory groups that advise the CDC or advise the FDA that collectively have that expertise, collectively have read those papers and give very good advice that have caused us to live longer than we did before. But again, trust me, I'm an expert is not exactly a message that sells in the 21st.
That makes a lot of sense. Dr. Offit, I want to thank you so much for your time today and for the amazing work that you are continuing to do.
Thank you. It's nice of you to say that. Thank you.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.